Thank you, Vanessa, and good afternoon, everyone. Thanks to John for the invitation, and I'm going to carry your analogy on a bit further with the Glastonbury, John. So I think if this was a slot, it would probably be the Golden Oldies slot that I'm doing here now. That's not because I'm planning on, this is not my retirement tour, and my voice hasn't gone, which seems to qualify you to do that slot, so it seems sadly. But it's because actually when John asked me to do this talk, which I was delighted to help with, I wasn't actually sure whether I would still be chair of the NIHR TRC, as it's known for short. But in fact I am until the end of April, when Kath Mummery, who some of you may have seen earlier on, will take over from me, with actually Vanessa and John Paul Taylor, who is in the audience today, acting as deputies. So the DTRC is going to be in great hands going forward. This work that I'm going to allude to, and I'll come on to it in just a second, has been largely crafted with John O'Brien, great friend and colleague in Cambridge, who's also here today, and John must take an awful lot of the credit, along with Sharon Denley, who is the Collaboration Operations Manager, who's based in Newcastle with me. Okay, but before we get into that, I'm going to kind of pick up on some of the themes that Vanessa and John actually both alluded to, but particularly Vanessa in her really nice overview at the start. I mean, I think we shouldn't beat ourselves up too much. The UK is still a good place to undertake clinical research in dementia. We've got really good people, we've got really good places, and, as been alluded to by others, the linkage to the NHS, which we've heard exemplified actually in the last brilliant talk by Richard, is a major asset that we often forget because we're immersed in it. But I think we all agree, and I'm obviously using some of George Freeman's lingo here slightly, as you'll have spotted, we're not maximising our potential to be a trial superpower in dementia research. So I've already alluded to some of these strengths. We've got some great infrastructure. We're here today, the DPUK, an absolutely amazing platform. The DRI, again, looking at the more basic fundamental aspects of dementia research, something to be proud of internationally. I'd like to think that the DTRC, which set up originally, just to remind some of you who are less familiar with it, it was actually originally conceived from biomedical research centres funded through the NIHR, who had a dementia theme within them. Because there were not that many BRCs who had dementia themes, they then expanded to include some centres, and I heard Ross ask a question earlier on from Manchester, who were incredibly active through their CRFs, their clinical research facilities, and Ross is a great example of that, and Exeter at the time. So it expanded somewhat. We've also then, of course, got these other facilities that I've alluded to, like the research network, the research facilities, which are phenomenal for the phase 2 studies, and the NIHR bioresource. We've got things like the Alzheimer's Research UK Drug Discovery Alliance, and I've already referred to the quality of the people, which industry like to speak to because they are seen as KOLs. So this is casting the clock back slightly on the TRC makeup, because actually it's evolved, and as you can see now, we would have more coverage with Exeter actually having a BRC, for example. But it was somewhat selective. I think that's the key point that this slide is making, and that at one point we reached out to Craig Ritchie in Edinburgh to bring in their CRF and Edinburgh as a whole, because of course the NIHR primarily covers just England. So we've got the great facilities. A lot of these places referred to on the map here obviously have got the PET MRI, which we heard about before the break, as well as the clinical research facilities. But the UK dementia research landscape is pretty confusing, and I often wonder what it must be like to colleagues in industry, for example, coming in from outside and seeing all of this. This is a graphic which kind of illustrates where the different infrastructure maps onto the different phases of the studies that one might be looking to do. So I've already alluded, for example, to the DRI being much more rooted in discovery science. We've talked about, well, John's introduced, and here we are with DPUK. I mean, that is spanning quite a broad area through multiple linkages, through the preclinical, now into phase 1, phase 2. Obviously, I'm here representing the DTRC, which is very much rooted in the sort of phase 2 experimental medicine. And John O'Brien actually leads the Dementia Clinical Research Network, which is much more in the phase 3, 4 area, with many more sites able to do those studies. But it's, as you can see, a pretty complicated setup. So the sort of issues that we're needing to address, and which Vanessa put some numbers on in her introduction, is we can't assume that where we've got centres of excellence actually maps to where it's needed. And so we really do need to be a bit more savvy in terms of matching need and access with capacity and excellence. We're not good, actually, as again we've alluded to, of linking NHS services, which may be really excellent, with research. We really struggle to get the workforce capacity and capability, particularly in the dementia space. And in the UK, that's very heterogeneous in terms of neurologists, care of the elderly, old age psychiatrists, and so on, as well as nurses who bring a huge amount to the table and other non-medical allied health professionals. So building this workforce has always been a bit of a challenge for a whole raft of different reasons. And we've heard about the damning statistics about how we're really not fulfilling the needs at the moment of industry partners. Possibly it's because of the complicated landscape and they don't see a clear way in. I suspect that's not so much the problem at all, actually. I think it's far more to do with some of the stats you saw earlier on about the time to set up studies, harmonizing of contracting, which is painfully slow, those of us who've been involved with this over the years, and recruitment, to time, to target, to try and get the right phenotype patients in, to minimize screen failures and so on. If I was sat in industry, these would be the kind of issues that would be driving me mad, and obviously is what would drive them away from the UK to places that can deliver more rapidly in these areas, because time genuinely is money to industry in this situation, as we all know. So I feel like I'm sort of Groundhog Day talking about this again, because we've all been at multiple meetings where these issues have been raised. One glimmer, one evolution, which is nothing to do with myself, but Claire Mackay in Oxford has been a real proponent of what's called the Brain Health Network. And this is a way of linking NHS service with research. And I don't want to dwell on this, but the point is it's designed to try and bridge that gap between NHS dementia services and increasing patient access and involvement in research. And you can see here from the graphic that already there's clearly overlap with where the DTRC sites are, but it goes beyond that as well. For example, including Northern Ireland and also sites down in Wales there as well. So it's a broadening and an expanding network, and even this is now not up to date, so there are more sites coming online. So this is a great way of trying to, if you like, feed potential trial subjects into the hopper over a wider geography to reduce equality and access issues, which I think we all feel very strongly about. Okay, so what I'm going to just spend the last few slides talking to you about comes with a little bit of a health warning. So this is work that John O'Brien, as I mentioned before, Sharon Denley and myself have largely led on in collaboration with the NIHR and the Department for Health and Social Care. We're going through due process at the moment to try and get this over the line. And I would also like to thank, and there are probably several of you in the audience that I'm unaware of, but I know Vanessa certainly has commented in a very helpful way in terms of helping to shape this proposal. So what we are looking to do is have a funded, coordinated network that aims to benefit many more people with dementia, giving them the chance to take part in clinical studies, particularly the phase 2 space, irrespective of where they live in the UK. In particular, the proposal targets building capacity and capability to undertake this excellent research, and to do that all along the way, working closely with public and patient engagement, involvement, as well as with industry partners, in particular linkage across to the emerging neurodegeneration mission. And I see Rob Buckles here today, who's leading on that from the MRC perspective. So what are the key elements to the proposal? Well, it has got the DTRC sites that I referred to before at its core, but the idea with this DTRC trial network is to expand it significantly to at least 20 sites. Maximising synergies with other infrastructure, it will not surprise you to know that there's a massive congruence with the sites that Vanessa showed on the DPUK trial delivery framework, and that we see as absolutely fantastic opportunity to work in harmony to try and pool expertise and resource rather than causing confusion and duplication. I've already alluded to the importance of the close links with the NHS services, and that will be a given for these sites. We will look for centres and expertise that is capable of delivering well-phenotyped participants. This is not only just in Alzheimer's, but it's in non-Alzheimer's dementias as well, like Lewy body dementia, like vascular dementia, and so on. And we will have to look at these sites quite critically, not only just at the start, whether they can, for example, step up and recruit a minimum number of patients, for example, with early Alzheimer's or MCI, with relatively modest and not excessive screen failures, and manage to keep their interest and their momentum going throughout. And when we've had comments and feedback, this idea of go, no-go criteria to say, yes, you're in, or unfortunately, you've just not been able to deliver what is required as minimum criteria, will have to apply, as will this networking and performance-driven ethos throughout. Now, this, as you can see, is courtesy of Vanessa, and this is kind of just showing you that this is not working in splendid isolation, what I've just told you about. And the idea will be very much to integrate with the DPUK trial delivery framework, which continues to evolve almost in parallel with the proposal that I'm telling you about just now. But I think very much the idea of the DP trial delivery framework will be to act as an adjunct to help with the phenotyping, the recruitment, and to feed in the hopper to get more patients through quicker into the relevant studies. And I'm sure Vanessa may also want to comment on this during the questions if necessary. So we're going to have key deliverables. We can't just take a large amount of money through NIHR and the government and deliver nothing. So the idea will be very much to try and increase the speed at which we can get trials approved. We will be looking to, as I said before, get this proof of capability and commitment with active performance management. We're not going to go wild on an all singing, all dancing database. There will be a minimum data set available and from information gathered from the sites. We will, though, put a major emphasis on upskilling, capacity building and retention, and that's where a lot of the budget's going to be directed. So the idea is to be inclusive. The idea is to try and include people from all walks of life, be it nurses, non-medical allied health professionals, be it doctors, with the emphasis on growing trial expertise in dementia. And one of the sort of flagship elements of this, which we don't have time to go into just now, is what we've called a Trial Investigator Fellowship Scheme, which will, in effect, give funding for up to 3 years for part-time research buyout while the colleague remains with the NHS to allow their time to be backfilled, but for them to really dedicate concentrated time to building the research capability and their own career development. The sort of notional operational structure that we've proposed, we'll have a steering committee, which you can see at the centre at the top. Obviously, that will be informed by an external international advisory board, and that in turn will draw on a number of the initiatives that Jeff referred to, such as the Global Alzheimer Platform, the Alzheimer Disease Data Initiative, and so on. And they're not exclusive. What I've put in that box, they're just examples. There'll be a study adoption committee, because if this does start to hit capacity issues, which will be a nice place to be, we might have to start prioritizing certain studies. The operations group will be drawn very much from the participating sites, chaired by the director of the network with an operations team, and that will be quite a departure from that which we're used to, certainly in the DTRC. This will really put a lot of oil into the wheels to be able to allow things like non-disclosure agreements, trial setup arrangements to be harmonized across sites to try and make it faster for industry to be able to get their studies through to first patient into study. The important elements along the bottom are almost self-explanatory, but the majority of these will have representation in each of the different trial sites, a sort of distributed network, if you will, with leads that will feed into the steering committee. One notable exception would probably be the methodologies, where the emphasis will be on recruiting colleagues with the relevant expertise in the relevant areas. The sort of KPIs that we're looking at in terms of this piece of work, and again, there is no time to go into this in any level of detail, but it will be the implementation of a common contracting model, reducing trial time by the order of magnitude that you see there by 2 years compared to baseline metrics. We will have to run a pilot study to ensure that sites do have the capability and capacity to deliver. And what we're talking about is each site recruiting in around 15 patients with early Alzheimer's disease, with about a 1 in 3 screen fail rate. Anything outside that or below that will start to raise alarm bells. We also will want them to be recruiting controls as well. We're talking about trying to be running that number of phase 2 trials at any one time. And we're talking about trying to increase the number of NHS employed staff directly funded by the programme over the course of the study. So I'm going to make it easy for you, because actually these are the sort of things that are probably going through your head. So Gold Star Network, but at what cost? We're still working our way through the budget, but this is not cheap, as you can imagine. It's a 5-year study, or a 5-year programme, I should say. How feasible is it really to bring people in to the workforce at the expense, if you will, of the NHS sessions that they might already be doing? Those of you who work at the coalface, if you like, in clinics and so on, may realise that may be easier said than done. But there are ways that we've certainly managed to do that in Newcastle in terms of having early discussions with medical directors and so on, in order to allow this to happen quite successfully. Will it be sustainable beyond the end of 5 years, or will it just drop off a cliff? I think the idea will be that if we are successful and this appeals to industry, then one would imagine a model whereby you would top slice fees to the centres to allow the central operating team to run in perpetuity at steady state, and that the network in itself, because of its success, would become self-sustaining, ? And you know, those of you from industry in the audience here, and I know there are many of you, is this the kind of thing that is attractive to you? Vanessa, thank you very much.
Questions for David?
Thanks. Hi, thank you very much for the talk. Of the sites proposed in the network, are they all secondary care sites, or are you looking at primary care as well?
That's a brilliant question. So they are secondary care sites who are, by the metrics that we've had from the NIHR, very research active, and we know that they have that sort of expertise already. But one of the feedbacks that we've had is very much that we should be linking into primary care. And I see that as essential because of the points that were made before the break about getting in early. And I think that will help with the denominator and feeding in from the hopper. So it's a really great point, and yes, that will be included, that linkage. That we have, the possibilities available to us with working across networks like the Trial Delivery Framework, where we have a lot of sites that are less research active, and actually through our DPUK partners, the possibility of accessing primary care sites as well. So I think this is where we need to coordinate in a very sensible way and think about where our strengths lie. Yeah, and I mean, I will just say, without embarrassing her, but I mean, it is going to be a real strength having Vanessa as the deputy for the DTRC, whilst also having her role with the DPUK. And I think Kath Mummery I know Kath very well from the Association of British Neurologists, and I think that'll be a really great way of taking things forward in harmony. There's clearly a plant in the room here with that table.
No, I'm
I
sorry.
think this is good. No, it's great. Go for it.
My question, first of all, I think it's brilliant. Thank you so much for your time to kind of take everyone in this room through it. I think particularly, the composition of the room, it's important that everyone have an opportunity to opine and be able to discuss this before it launches officially kind of later this year. I was really encouraged to see the study adoption committee, and you mentioned it, like if the success is there, then studies will start to go through there. Have we considered the studies going through there from the start? So thinking to what Vanessa just said about, being able to place things in primary care and secondary care, or maybe some less research active sites, is there not maybe some benefit to having a committee that is as a checkpoint, at the risk of putting another checkpoint into the infrastructure, but one that's really useful to be able to then decide exactly what sites these sorts of pieces of research are best for? Whether that be different arms in different sites, or rather, things that can easily be deliverable in the community, happening in the community, then freeing up space in those crucial secondary care sites to do that more all-important work.
Yeah, I think I'm going to be slightly liberal possibly in how I interpret your question, because I'm not entirely sure I understand the point, but I think I understand what you're saying, that this is a crucial resource and that it will have finite capacity, and we need to be canny in terms of who does what within the overall system. Maybe I'm paraphrasing you slightly wrongly there, but what I would say is that it's not the way that I was thinking about it, coming down, reading this, is that this will work probably in fractals. It's not going to be that every site will do every study. It will be a case of kind of playing to the strengths of different sites. So I would speak for Newcastle, where we have a big strength in Lewy body dementia. We may be taking a lion's share of studies in that space, along with places like Exeter and other centres that are really keen to do that work, and maybe not so many in terms of the Alzheimer's, depending on the capacity required for the study. It may be that the adoption committee, I mean, the exact composition is to be determined, and it won't be for me to determine that. But we have really tried to have multiple stakeholder involvement in that and the steering group. So there will be read across to the neurodegeneration mission, for example. There will be read across to people who are not just bedded in. There'll be charity representation as well on those groups. So it's quite a broad constituency to help guide and switch as to where the study might be better done.
Around, will it exist from the start? Will all studies follow that path, or will the study adoption committee, or will you only put that in place if it gets, as you say, oversubscribed?
Oh no, sorry. Okay.
I should have been more clear with my question.
No, I get you. No, absolutely. That will not be only brought in if there's a capacity issue. That will be it from the start. Absolutely, that's the intention. Yes.
Wonderful. Thank you.
I'm going to move to the next speaker. We do have a general discussion period at the end, so if there's any other questions, feel free to save those for later. But I'm just one last thank you for David, please.